Yes, thank you again, Dr. Boko. I will begin a presentation which is not so traditional. There must have been a problem with the audio. This is not so traditional because my presentation is related to the challenge that COVID-19 had us face worldwide. This is a year that we started celebrating, and then there was news of a new virus that caused a situation which was led to an outbreak in Wuhan, and then suddenly the whole world was facing this pandemic from a virus that until then we had not had to face, and that put the technical cooperation had to face a great challenge. We had to face many limiting factors. This is not the classic presentation that we usually present with Dengue. It's more in the field of management. I will focus mostly in patient care, which is one of the main priorities that our organization has to avoid deaths in the countries of our region and severe cases. As I said, we will divide the presentation into three parts. The first one will be the general context that has already been presented. Then what we call new modalities of technical cooperation for patient care component, which is where I want to focus, and future technical activities that are now ongoing. Although this was already presented in the previous session very well by our colleagues, specifically Bart Gamaliel, I would like to use this slide to underscore that although dengue, Zika, and chikungunya, the first three bars that we see in dots, are present in almost all countries, in this measure, all countries in the region require technical cooperation. And this is a task that is quite stressful, a disease that has cycles that are frequent. So the demand for cooperation is really continuous throughout the year. Now, reinforcing what I just said, you can see in the lower panel of this graph the large epidemic cycles that our region suffers. And in the last 2 years, 2019 and 2020 so far, we can see how whenever we follow an epidemic year, the epidemic year doesn't mean that it's strictly limited to those 12 months in the year as a calendar year, and so it extends. And then we started one year, as was explained, with a situation that was quite tense regarding transmission. And the upper panel is an internal channel that we use for follow-up. And although there is a drop in the curve caused by several elements that we have seen in prior presentations, on certain underreporting, the situation of isolation or confinement to people's homes, the lack of mobility of the population, all had an influence. But we see that the virus moves regularly. That's why when there's parties or carnival and when there's dengue outbreaks, sometimes the government ban those great um, numbers of population or parties, and then we see that there is transmission if those happen. This is sort of an abrupt drop caused by all those reasons, but we're also now living epidemic year. So we were expecting a drop, not so marked, but if we look at this, we have maintained this channel throughout the year. We have within a zone of alarm and at the beginning of the year in the epidemic range. Next slide. And this factor which we are excluding in this graph, the cases of COVID-19 from the US and Canada because they don't have dengue. This is the COVID that occurred in countries of the region when there is active transmission of dengue. And as COVID reporting increased, the other one decreased. But we're not talking here of underreporting. We're speaking of more than 2 million cases. Possibly the second year, more cases will be this year. So it's not like it's a year with a when we must stress our technical cooperation, but rather we need a high technical cooperation this year. What is the type of technical cooperation that uh, is provided by the organization, and what happens usually? What you see to the left is the um, integrated management strategy, IMS, with all the specific areas and a component of management. And there's these two horizontal lines of operational research and community participation activities that were also limited. And surrounding it are a series of facilitating factors. As countries progress, they also progress in those processes. Technical cooperation is focused on each of those components and does not occur by individual areas, but rather as a package of technical cooperation. One of the most important activities for us is the assessment. More than 40 evaluations throughout the region. Other frequent activities are shown. These are teams that go to each country during about 1 week. The country has been preparing previously, and they undergo the evaluation uh, activity with all the members of the team. We also have the clinical training, and frequently we carry out trainings to facilitate it in large workshops with by sub-regions and then are replicated in individual countries. The activities for vector control are many as well. The adjustment of the national response models, those are areas that do not occur in periods of crisis, but rather between crises, where we adjust and have a scientific exchange with the teams, between the teams and the countries to improve the preventive strategy and to cover the gaps as well. Also, the strengthening of the surveillance system, subject that was mentioned in the previous session, and something that has to occur in such an intensive year of cooperation, which is the response to the control of outbreaks and epidemics. All this is carried out with great mobilization of the PAHO technical staff present in the countries as well as in the headquarters, and all this is implies mobilization of the Arbovirus task force. But to this, we have to add the pandemic of COVID-19, which of course um, did not allow for this mobilization, so we cannot actually provide the traditional type of technical cooperation we used to provide. So, what has been immediately limited in all countries? This is at the regional level with regards to country support. Resources were deviated immediately to address COVID-19. Human resources and material and financial resources as well. Our staff is now dedicated to disinfection tasks, to personnel in vector control, that personnel that work in vector control, and even imports of materials is affected, and the whole world economy was affected. We have also important impact on the healthcare personnel. We've had to suffer the death of colleagues that could have been working in various countries of the region that were affected and deaths occurred. Also, the healthcare units had to be prepared to receive cases of patients with COVID-19. There's two elements that, of course, remain unchanged, at least not for the good. The determinants of dengue transmission continue to exist, and even because some activities were now left aside in sanitization and environmental care, although in worsen the situation in many areas. And of course, the situation of dengue transmission continues, although somehow modified. We're speaking of more than 2 million cases and more than 4,000 severe cases, and we're have more than 700 deaths, but we have an overloaded healthcare system with more than 16 million cases of COVID-19, which of course stress the whole system, and the system has collapsed in some areas, and with more than 500,000 deaths worldwide and 54 countries involved. So we're now facing a disease which is preponderant, such as dengue in Latin America, and that of course involves many resources of the health system, but now we have this situation superimposed, which interferes with the traditional cooperation aspects of regarding dengue. So we will now address those new modalities that we have mentioned, especially the patient care component, given this challenge. The first thing we did was to make a diagnosis. In the first few months, it was still the containment measures were not so strong in Latin America, and there we carried out three meetings, one with the Andean countries, another one with the Mercosur countries, and another meeting with the Central American uh, countries. The three sub-regions held meetings. We prioritized the needs. We looked at the more urgent needs at the time. So an initial diagnosis was made. Now, having that diagnosis, we then carried out specific meetings with key countries, Mexico, Colombia, countries that have historical problems with cases and mortality, such as Dominican Republic. So analysis were carried out with the technical teams in the region to have a good diagnosis of the situation. We then called upon the international team to try to see how we could face the limiting factors. In that brainstorming, the first thing was to see what we had at hand as resources that could be used. We explored the platforms, existing platforms that required no investment, and just using what we had. And there were several virtual meetings with our technical team. After that brainstorming, a group of experts within the organization and also from outside the organization summarized the ideas that could be implemented as new cooperation forms that could reach the countries. In this implementation process, it was decided to begin with a clinical component because avoiding severe cases, and this was our first priority. So the patient care group of that international team was 100% involved. Even new professionals were recruited from various countries, and also the national authorities were called upon. Can you hear me? And the national authorities had to be involved completely in implementing these new modalities. This slide shows the materials we had. We had two key documents that were going to be the basis for the cooperation. The guidelines that were being updated. There is a section for the guidelines as such, and today, and also the instrument for the diagnosis and care of patients. But we had to reinforce the algorithm for the clinical management of dengue cases. That document was elaborated in that time frame so that it could also be used as training material to be used quickly. We then divided the cooperation of the clinical area in two areas. The first one was the formation of a network of clinical experts. We have a GT dengue that could not be moved, but those are distributed in the various countries. There is also a group of physicians that have historically worked in dengue with in the various countries, and we had to bring them together. And that was the idea that we created um, the basis in the countries to be able to work in technical cooperation. So we thought in national networks of clinical experts in order to advance in patient care and patient management. The other aspect was to try to rapidly activate the training process and the continuing education for medical and paramedical personnel. And the idea was to have virtual courses that could address the issue of dengue in the first place. There was one experience that was used, which was the RELDA, the network of dengue laboratories in the Americas that had functioned for more than 10 years as a structured, systematic meetings, and results that were quite measurable. So the network that was already in place was used as the basis, and we started working at two levels, a regional level and a national level. The regional level required standardization of the training models. We could not have a training process unless we had a systematic approach and protocols, methodologies for teaching that were going to be used in the transfer of knowledge to the countries. And there's a working group that had several meetings a week. And I have to say that this was voluntary because this was personnel that took hours outside their working hours and worked in the standardization of those documents. And at the national level, strengthening technical scientific capacities. We started that process in Mexico because the demand for cooperation at the time, and we formed a national network with 4 national reference and 32, each of one Mexican state, in order to help with the training process. And the second country was the Dominican Republic with 4 national reference and 24 from the various states. We carried out 2 training sessions with standardized materials. All the presentations were sent out to the countries, and we had 2 sessions a week during 3 weeks. The sessions lasted 1.5 to 2 hours, where all doubts were clarified so that we could send out a standardized message to all. That work that was started in those 2 countries, once we finished the first one, we realized it was not sustainable throughout time because it required those for those professionals. The Arbovirus GT had repetitive sessions and the contents were repeated. So we had to create a more sustainable path. So we required we had used the virtual um, teaching uh, room, but we also thought the problem is not only the patient care. We have to work in the laboratory areas and with similar methodologies, the vector management, epidemiological aspects, and that regional teaching system is designed so that under the IMS, there is a forum, a permanent forum that is active and alive for exchange of technical advice and communication. The entry to this classroom is not open. It's targeted to those professionals and um, sectors. The sessions are well planned with the Ministry of Health of each country to prepare 2 or 3 countries at the same time, or maybe one country. And 7 modules were designed. You can see them in the slide, and what you see to the left is already the virtual classroom that was prepared, and those modules consist in pathophysiology and organization of health services. So all this training continuum, which is module for continued education that are followed year after year, have the advantage that they are targeted to primary care physicians, and that is where we can have the highest impact in prevention of severe dengue and death. Even in current times, to be able to defend the secondary care units, because if we're able to manage well dengue with signs of alarm, then we can avoid those patients to go to the uh, third level or institutions that are really destined to care for the victims of the pandemic. This virtual classroom started working. Oh, sorry, the other. Let's stop there with the virtual classroom, and we'll see the other modality of work. The second one that we wanted to achieve in a short term and reach many professionals and have the possibility of reaching them soon, we prepared self-learning dengue course, which consists of 20 hours of teaching and is in Spanish. Now, that course is now being prepared in English with the English version. So they're currently working on the fourth module for the English course. And there's a plan for virtual courses and the other components, the laboratory component, the epidemiology component, so that the plan is to cover all those other areas. We're already planning what we're going to do with Zika and chikungunya. And hopefully, before the end of the year, we will possibly have another of these courses ready. The first thing we learned is that there was a gap in the region, in the technical cooperation. The course was held 1 week September. To 1 week there was no promotion, no dissemination about the course, no publicity. So that was sort of a prior assessment phase. So if we look at this as of September 10, the uh, promotion of the course started, and up to now we have more than 6,000 people that have been involved in the course, self-learning, and more than half of them have already obtained their certificates. This is a certificate that is signed by a PAHO director. Now, this course, which is currently active, it doesn't just mean that we have a course. This is just one step. The interesting aspects are those that come later. We have a continuous monitoring of the course and a continuous exchange with the focal points, because this is technical advice. This modality was not present for technical advice, and we see that those countries that have already many professionals that have been reached and involved, Ecuador, Mexico, Colombia, Costa Rica. See how interesting. 68% of the participants are women, very young ages 26 to 35. So we are actually reaching a medical and paramedical population. Some are even recently graduated. 64% is working at hospitals. Initially, we had more incorporation of primary care, which was 26%. And you see an interesting thing. In the follow-up and management of the patient, nurses have a exceptional role, and 27% are professional nurses dedicated to the course. We also have other health technicians that are involved. We also looked at the other countries which are involved and that need to make greater effort in promoting the course. We just had a meeting last Friday with Guatemala, looking at the national strategy for dissemination, and in parallel to create the net, physicians network. That is a continuing education program with the new elements of the clinical guidelines, which will be mentioned later. So based on those new elements of the new guidelines, and we're continuously negotiating and having incentives, empowering the ministries of health. Some ministries of health have now uh, made it mandatory for some of their physicians to follow the course. What are the future activities? Because so far I've spoken of the clinical aspects. There are several elements, and assessment is a key element. This was mentioned, that evaluation is a way of closing gaps, of making sure that we're using the right elements and having the right prevention elements, and to be able to understand what is happening. You cannot conduct a program only virtually. We need to assess, we need to we need to monitor the indicators, see how the institutions are doing. And those capacities are currently, of course, very limited because of the current situation. So the first thing was to standardize the assessment elements. So the methodology for standardized evaluation is essential. And I'll speak of evaluation because we need to look at the standardized indicators. You have three priority levels. We have priority one, which it has an immediate response. Priority two, that requires a response, but not necessarily um, immediately, but in the first 2 months. And then there's priority three, where some can be left out with less impact on the results. And this is the validation of the assessment instruments. And two assessments were performed last year in Paraguay and in Ecuador, where the model was implemented and the assessment was standardized. We are speaking of something that could be a self-assessment of the country or an assisted evaluation. So far, the idea is to have a sort of self-evaluation that is also assisted. So we would need two teams, an international team that doesn't travel, and a local or national team that is very well selected by the countries, making sure of the quality and transparency aspects, a joint agenda, a single document, virtual sessions, pre, during, and post assessment, and those will be working together with that assessment with national and international experts, and that will allow us to know how the country is doing. Colombia has already requested that self-assessment. We're preparing for the first trimester of 2021. Other countries are also requesting. Mexico is another country that has the possibility of doing this. So we already have um, plan to complete in the next few months. What we need to write very carefully and describe carefully is how the operational model, the practical model is going to be. How do we put this in practice on site? But that needs to be done as soon as possible. It's one of the processes of new forms of cooperation that needs to begin ASAP. And in order to be able to correct or fill in the gaps that could exist. And I would also like to mention that this is not the work of just one person or the PAHO team alone. This international team that and has generously dedicated so many hours to this work. This is a large group of 30, 40 professionals, and there is this technical document that has been circulated throughout the organization and has been analyzed by other technical teams as well with these new modalities. I've mentioned three among several that exist, because I believe that these three have a high significance with regard to the approach of these diseases, arboviral diseases. The first one is the preparation of a tutorial. So, of course, the people go to the various houses, do the daily work, and try to find the breeding grounds in the houses and destroy them. So the idea is to have like a virtual operator that guides the family or those people. We always ask the family members and the community that lost all their capabilities. We no longer have the community interventions as we used to have because we don't have that in cleaning activities, sanitization, all that is now impossible. So that virtual operator can convey the knowledge and explain how to do the or carry out the control of the breeding grounds in the homes to eliminate the vectors. And it's not like it's on the platform and whoever wants can see it. We need to implement strategies in the country so that that reaches the families, and we also need to verify that action is actually taken by the family. The other point is the development of an online toolkit to guide decision makers at the local level towards key activities for prevention and control of arboviral diseases in those countries. And there's experts of different disciplines preparing those toolkits in order to orient and provide elements, governance, local elements, to small communities and also mid-sized communities, and explain how one person can um, explain how to improve the environment and to close those sanitization gaps. And finally, the idea is to prepare short information capsules and video to disseminate by all possible means of social media, Facebook, YouTube, etc. Because the group concluded, and so every day, that it's suddenly there's a lot of people that we've never seen working in arbovirus. Maybe the countries don't know them, and then they will say, well, will they give it, provide information that we can't check? So sometimes, unless we do that, those areas will be occupied by information that sometimes are more deleterious than helpful, and our specialists maybe are not known, like Dr. Bosco, like Dr. Martinez, all those specialists that are so well known. So the goal is to work intensively. We've already had two meetings to explain how to develop this in the epidemiology, to explain the true epidemiology of these diseases, as well as the clinical message and the social communication. We have teams that are experts in communication that are helping us, and they can be disseminated via the social media with clear and concise messages. With this, I have reached the end of my presentation. I know that implies a lot of work. Some are just starting, but these are technical cooperation modalities that some already are being implemented with very good results. And this is very important, but will require involvement and the effort of all our countries in the region. Thank you for your attention.